Good evening. Greetings from the 603. This is Dawn, and we're going to pick up where we left off. And this slide is talking about warning signs in the laboring mother. For those of you in the alternative class, I believe we did cover this slide. For those of you in the evening class, it's a slide that we need to discuss. So we just came off of the slide that talked about stages of labor right here. Talked about all the time frames, the characteristics of each stage, the mother's psyche and the change in her psyche, and nursing care. So some of the things we want to pay attention to are those classic or important warning signs that we wouldn't want to miss. On the maternal side, it would be marked changes in vital signs. So we're talking about significant changes. We know that as the woman labors, she can have some subtle blood pressure changes due to systolically, due to pain, and we know she can have some increase in heart rate due to pain. But a good example of that would be you admitted this mother into the labor area to labor, and maybe perhaps she had a blood pressure that was fairly normal, 122/78, and as the labor progresses, you note that her blood pressure is trending upwards, and 4 hours into the labor process you see or assess for a blood pressure that's 160/88. That would be a marked change. So that's something we need to pay close attention to. Contraction patterns that are not effective, perhaps is prolonged. We talked about that 90-second rule on the last slide, and any coupling or too frequently. Again, a warning sign. Abnormal contour of the abdomen, a sudden shift in the shape of the abdomen, and then the mother's feeling of impending doom, her apprehension, restlessness, something's not quite right. We should take that very seriously and pay close attention to it. In regards to the fetal warning signs, the fetal heart rate, if we note that it has, the fetus has a prolonged or an extended period of bradycardia or tachycardia, we must respond immediately and note that. Meconium staining can be a warning sign. Extreme hyperactivity, a sudden onset of extreme hyperactivity, can also be something that is a potential warning. And any evidence of a low oxygen saturation or ABG, and those can be monitored during the delivery through internal monitoring devices. I apologize for the bumpiness of my camera. It's my voice and not the slides that you need. So assessments during labor are going to be vital signs, obviously, frequently, and we're going to determine the fetal position and lie, and we talked a little bit about this in class by assessing where the fetal heart tones are heard loudest. Depending on where they're heard in the abdomen, will correlate with the baby's lie. Leopold's maneuvers are covered in your textbook, and they're used to palpate for the fetus spine, and then differentiating between the buttocks and the head to determine fetal lie. We could also use the sterile vaginal exam as a means of determining presenting parts in fetal lie, as well as ultrasound. Determining the status of the membranes. When membranes are ruptured, whether it be artificially or spontaneously, AROM and SROM, we want to pay particular attention to the color of the fluid, if there's any odor, always assessing that if there's any presence of cord that may have prolapsed, that would be a big complication, and we'll cover that in our complicated labor lecture. And then also to knowing that once the mother's ruptured, there's increased risk for infection. So we'll minimize those sterile vaginal exams in the event of rupture of membranes. We want to determine pelvic adequacy while we're performing sterile vaginal exams, and we want to examine their labs, in particular the CBC, pay close attention to the H&H, her GBS status, blood type, and also a urine analysis. As far as the contractions are concerned, we spoke about this in class earlier this evening. When we talk about intensity, it's always done through palpation, and we're measuring duration, intensity, and frequency. Duration being the length of the contraction from the beginning to the end, the intensity, that mild, moderate, and severe, and frequency. The frequency of contractions, we time them from the beginning of one contraction to the beginning of the next contraction. This can be done, the only other way besides palpation is that's accurate, is through the use of an intrauterine pressure catheter, and that can also be inserted for more detailed monitoring. Please don't forget that we also get a history of the pregnancy, medical history, surgical history, family history, and we do complete a physical exam, a head to toe. We want to gather all informed consents from the parents and make sure that we've paid close attention and reviewed the birth plans with the mother and her support team. And then just a little note about EMTALA or EMTALA. That's the Emergency Medicine Transfer and Labor Act, where labor does fall under that national act where we cannot refuse care. So if a woman arrives to a facility and she's assessed to be in active labor, by law, we have to provide care to that woman, just like we do for anyone who has a life-threatening event in the emergency situation. The next slide talks about the fetal assessments. So we assess mom, but we're also going to assess the fetus. We do that through electronic monitoring. That is the preferred method of monitoring. And we're looking to establish a baseline of what this baby's heart rate is. We know that fetal heart rate is normal at 110 to 160. And once we've confirmed that the baby's heart rate is within that normal range, we're going to look at variability. And variability is defined as beat-to-beat changes that occur. What we would like to have is moderate variability, which is 6 to 25 beats per minute. So that would be defined as a baby who presents, once the monitor has been applied, that this baby's heart rate might go from 124 to 132 to 136 to 128 to 130 to 136 to 138 to 135. And there's that variability that exists. That's a moderate amount of beat-to-beat variability. A lot of times people will think, oh, well, if they had marked, that's better. That means it's greater than 25 beats per minute. Marked variability can be a concern if suddenly the baby has marked variability. So it's something we do watch and pay attention, especially if it's prolonged. Minimal variability would be anything less than 6, and absent means there is none. There's just no variability beat to beat, and that both of those would be, absent in particular, would be very concerning. We're going to notice if there's any changes in that fetal heart, like accelerations, which are good, and those should be seen with fetal movement or contractions. And that's when we have an acceleration or an increase in the heart rate by 15 beats per minute that last at least 15 seconds long. Or decelerations. The baby's heart rate falls from the baseline for the same period of time, 15 beats, 15 seconds long, and those could be either classified as early, late, or variable, or prolonged. And we'll discuss in greater detail decelerations when we talk about fetal monitoring in the complicated labor. But for now, we want to at least know that our role as nurses is that we're going to be assessing the fetus during the labor process and their tolerance. And those changes, those decelerations, with the exception of early, those can be indicators that the baby may or may not be tolerating this labor process. And then we want to make sure that they're assess if they're transient, that they're sort of coming and going, or there's a predictable pattern to those decelerations. And then the 3-tier classification system for fetal heart monitoring. Tier 1 is a normal fetal strip where we see moderate variability, we see good accelerations with movement and contraction. We may see some early decelerations, which are indicators of some head compression. The baby's going to be born. And then you'll notice that Tier 2 and Tier 3 is an ominous predictor, meaning that we see something on that fetal monitor that will force us to make an immediate decision about the progress of this labor. So we might see something like a sinusoidal pattern, no variability whatsoever, absent, or lots of variables, late, bradycardic episodes. We would classify that as a tier 3 fetal strip. So tier 2 becomes anything that doesn't fall inside of tier 1 or tier 3. So we have to continue to monitor. We may have to carry out some interventions, but we don't have to make an emergency response like we would with tier 3. Next, we're going to discuss medications that are used in a normal labor and delivery situation. And the 3 medications that you're responsible for knowing would be oxytocin, which theoretically that's generic. It's we deliver it as Pitocin, which is a synthetic form of oxytocin. And oxytocin on your ATI, Pharmacology Made Easy, there's a nice learning module about this medication, and it is typically used as a labor augment to augment labor. It can also be used post-delivery to help the uterus contract. The next medication is methylgovine, and that is also known as Methergin. And again, it's used to manage bleeding and increase uterine contractions. Again, I want you to access your ATI, Pharmacology Made Easy. And then finally, we have misoprostol or dinoprostone. And these also are prostaglandins that are typically used to soften the cervix or ripen the cervix, administered in suppository form into the vagina. And all 3 of those meds are covered on your ATI, Pharmacology Made Easy. The next slide is preparing for the birth. So as the woman labors down and she gets close to that transition stage where she'll be, or a transition phase of stage 1 of labor, she'll be 8 to 10 centimeters. The nurse would want to make sure that the fields are ready and prepared, and that there's also been skin prep for the delivery. Any kind of equipment or aids or birthing aids should be readily available. That might be a squat bar. It could be special birthing chairs, balls, anything that we're going to see used in the birthing setting. And we want to make sure that we've assisted with positioning. Some deliveries do happen in the classic lithotomy position, so it may be that we're helping the woman into that position or holding her legs. The next slide is the role of the nurse during and right at the immediate birth. So once we've assisted with getting this mom and the environment ready for the birth and the positional aids are in support, typically our nursing care is directed at support for the family unit, and things that might be an example of that is breathing and letting the support person know where they can stand and where would they best be placed during the labor process. We do want to pay close attention to the status of the bladder during this period, because we do know that if the bladder hasn't been emptied, it can delay the pushing stage, and that's from full dilatation to when the baby is born. Our role when the baby is born may be that we assist in cutting the cord and clamping the cord, and we want to assist to bring that baby, if the baby is able to do so, to the mother and provide skin to skin. And again, if the baby presents and has good tone, has a spontaneous respirations with crying, and the color is improving, the baby typically would go skin to skin. If there's anything that we would question as to the extrauterine transition, we'll typically we'll go skin to skin, and we'll do some further investigation right there. And then, excuse me, assessing and intervening immediately following the delivery, things that we may be involved with or assist with would be perhaps fundal massage, encouraging that uterus to tone up, perineal inspection, inspecting the perineum for lacerations, tears, and episiotomy and repairs, making sure that everything is intact. Placental inspection, we may be involved with inspecting the placenta to make sure that there are no